Well, I think that one of the biggest challenges is cost, and I think that society is recognizing that we can't continue to deliver medical care the way we have in the past. And they've delivered the medical industry, and we are an industry, an ultimatum. And the ultimatum is you're going to have to change this or we're going to change it for you. And so I think that one of the things we deal with every day is understanding that we're going to have to change the entire paradigm. And one of the things that I think has happened in San Diego, and Rady and Sharp and a lot of other folks have taken a leadership position is in population health and helping to drive health out into the community. Because all of us recognize that driving health into the community and helping to create a healthier environment, and Nick has been a huge proponent of this, as has the community clinics over the years, is if we can deliver care in the community, whether it's through home health care, whether it's through visits with nurses and other professionals in the home itself, you are keeping people healthier, out of the hospital, reducing cost. It's a win for everybody. So I'd suggest to you that that is probably number 1, 2, and 3 on the list.
Cost, cost, cost.
We're blessed in San Diego that we're able to work together. To me, what's fascinating, the biggest change, and one that has really prepared San Diego well because we live it, is how the market is evolving nationally. One to become of co-opetition. And see, in San Diego, we're able to compete and collaborate at the same time. That is highly unusual, but yet it's required now. To achieve caring inside an institution to the community is going to require a great deal of collaboration outside the walls of institutions, across institutions. We're still trying to collaborate inside institutions for some of us in government. But how you succeed in a cooperative market is no easy task. And so what we have demonstrated for decades in San Diego is the ability to do that. They talk about big data and so forth. We haven't been calling it that way, but we've been doing that here in San Diego, clearly even with our trauma system. And Dan can talk more about that, was very involved with that. But what's exciting to me is that we're able to come together and really map out, what is the best quality across the whole lifespan, not just for the sick, but how do we keep people healthy? Everyone's heard about the sick care into the health care. I think we're going from sick care in San Diego, and we're not in sick care in San Diego. I would say we're more in health.
We're also contending with the huge primary care shortage that we have. And so while we are in this collaborative competition, there is competition. And so for some of us who have limited resources, right, it's a challenge. And so that's what we're contending with since the ACA had been passed. So now we have all of this folks that are now insured.
Right, ACA being the Affordable
ACA
Care
being the
Act.
Affordable Care Act.
Right.
And most of these folks are coming into the community health centers since most of them are within the Medicaid expansion, right? And so our doors have been jammed with folks, and we're not able to meet the demand as we have them right now. And so there's a lot of work around meeting those demands. I actually wrote my master's capstone on group visits, and so yes, we've been doing that. It's a very innovative. I thought that was a question down the line, but yes,
okay, right.
Yes, that's one of the things that we've been doing. Some more progressive organizations out there, such as the Cleveland Clinics and Sutter Health, they've been doing this for years. Even Kaiser up north has been doing this. It's a very innovative way of delivering service because you're then able to capture more patients with less resources.
what you stimulate for me, and I think my colleagues started to address, is if I look at the macro picture, we still have a major challenge today around healthcare economics. Dawn and others refer to the piece of it around the cost, but there's also a very huge challenge around what I call the revenue side of the equation. What we truly are still wrestling with greatly is how do we make certain that there is enough revenue to basically provide the quality care and service that we want and need, as we also redesign delivery systems and to focus on populations of care. Not to go too deep here, but one of the big issues, and I think sometimes an issue that's not had enough light that shines on it, if you take a look at most healthcare systems, their largest revenue stream comes from the government, Medicare and Medicaid. If you look at those two largest populations and where the greatest amount of the revenue comes today, that does not cover the cost of care, especially within the state of California, where you see some of the lowest Medicaid or Medi-Cal reimbursement rates. These colleagues around me know all about that challenge. So if you're losing money, if you will, or there's not adequate revenue to cover your largest population, how do you stay afloat? Well, you stay afloat, and we have historically, by doing something called cost shifting. So those who are insured and have insurance, they pay a lot more than cost to keep the books balanced. Well, what we know today, cost shifting is over. Employers can't handle more increases. Every one of us who contract as a provider have people knocking about reduction in rates. And when we keep moving those rates down and we hit the bottom, and we're not at the bottom, but getting closer and closer to cost of care being at its lowest, we have a real crisis occurring, I think, within this state in particular. So I would say our healthcare economics, our payment systems, and the cost shifting challenges are very, very large and huge.
The analytical skills to be both these, as what we just discussed now, big picture as well as understanding processes. So it's people, processes, technology, and having that type of analytic skills to be every one of the employees coming in being a strategist, being a service strategist, not to defer to the strategy department to do strategy. But we're looking for people to come in to each be part of that strategy development. And that's a little bit different because we typically, I'd like to say, we hired sometimes in the past for your hands or your skill sets. We want the whole person and the whole involvement. And so understanding the issue of data, when we say we're data driven, the contribution of whether you're in a service line or department or division, how that interplays beyond your own division across the entire organization, and then, let's have fun, across the entire community. And that skill set, that emergent skill set of being that integrator strategist is something we're looking for, but yet also a challenge in having people come in with those type of qualifications.
We continue to have challenges with recruiting qualified nurses. And of course, I'm in a very unique situation because we want someone who's got lots of pediatric experience. So I think we do continue to have challenges with attracting and bringing in qualified professionals, physical therapists, nurses. But I will leap ahead and say the challenge of the future is going to be IT. And it's going to be that across the board.
Learning how to do predictive analysis, right? A lot of buzzwords, and it's it's being forced upon us, really, from the Affordable Care Act, ACA, because that is the way to transform. Population-based health is all about mining that data and figuring out who the high utilizers are, who the folks are that are costing the system a ton of money. So, but there's not a lot of expertise within the current healthcare workforce currently. There's a huge issue with the decrease in physician graduates.
On the nurse front for us today, it's really about finding the experienced specialty nurse. Today, right now, within our community and our state, there's not this huge nurse shortage that we had historically, and it's very, very sad because many of the new graduate nurses, are coming out of programs and not finding employment. And that's because the new grad cohort has saturated the workforce, and what we're really needing in our EDs, our NICUs, our ORs, our ICUs are people who have experience as our population continues to age and become more complex. The other thing that's a challenge for us on the work front are what I call new and emerging roles, and the majority of them, not all, are really roles that are, again, calling upon some clinical background and knowledge. And so what we're finding is a lot of our experienced nurses are jumping into those new roles, such as clinical documentation specialists, so that we make certain all of our physicians are documenting for meaningful use and reimbursement issues, et cetera, as we prepare for something called ICD-10. So if any of you have any interest in terms of health information management, documentation, if you want a side job as a coder, you could be hired in a nanosecond, and that is a really large field. And then the other one that Nick referenced that resonated so well is really around leadership and management. We find it very increasingly more and more difficult for first level management roles and then second level management roles. In terms of workforce shortages and need around that, this population, first and foremost is psychiatrists. Our medical institutions, our academic settings are not producing enough psychiatrists today to meet the needs. And we also have to create greater incentives for physicians who want to work in acute care settings. We have a county behavioral health hospital and mental hospital. We have the largest one at Sarte in Mesa Vista. Both of us struggle with getting psychiatrists recruited to this community. And we're very fortunate, believe it or not, because we've got UCSD here with a strong psychiatry program who is feeding this community. So those are kind of, and probably second are advanced nurse practitioners in the behavioral health field is another area that I think we need to address. In terms of the question, in terms of the ACA and what type of roles would it create, did it create, and it kind of made me think of Nick's, freeway and the on-ramps, et cetera. I did a little, I went to the literature to find out, well, what did they say at the beginning around role job creation around the ACA? Well, my first surprise in terms of review, there was nothing mentioned about healthcare providers in terms of job creation. They identified 6 in terms of the articles I reviewed. And so I wrote those down for you. IT professionals, management consultants, lawyers, insurance sales agents, customer service representatives, and navigators.
We have a movement in San Diego. It's Dan's point about you have to have a vision. The Affordable Care Act didn't have a vision. The triple aim is not just a vision. Where do we want to go as a people? And we have something called Live Well San Diego. North County Health Services is a member of that. It's a collective effort of many, many providers beyond just healthcare that are coming together and saying, In order to build better health, you also need safe communities, because in the presence of violence, you can't achieve health. And we need to have the housing. You need to be thriving. We need to have education and thriving. We need to deal with poverty. And so you have to look at that. And if we're just talking about health, it's so daunting just to look at health, but to say, oh gosh, even safety and thriving. But in order to really transform a community, to live a long and purposeful life, you have to do those things. And that's what we're doing. And that is connecting, using technology, but connecting with leaders together and our folks, and paving our own way in San Diego to living well.